Hello, everyone. Good morning, good afternoon, good evening. Welcome to another Rafael Medina subspecialty virtual morning report. We're very excited today to have our colleagues from OHSU in the Pulmonary Critical Care Department here with us. Would you mind introducing yourselves and telling students and residents why they should go into pulmonary critical care?
Yeah, you bet. My name is Robin Stiller. I am new on faculty, relatively new within the last year at OHSU in the Division of Pulmonary Allergy and Critical Care. And I would recommend this specialty really because it is just such a wonderful team environment. We work closely with so many of our co-subspecialists. We get to learn from our consultants. We work closely with our nursing colleagues and respiratory therapists. It's just such a family in the ICU. So that's really what drew me to it and what I love so much about it.
And my name's Ravneet Raj. I'm just finishing up my second year in internal medicine at OHSU. I am also hoping to go into pulmonary critical care, and similarly to Robin, I think the team dynamics drew me, but also it's the one place where I think we can address patient care holistically through all organ systems, and also where family members, I think, play a much greater role than in advancing patient care and having goals of care discussions than I realized. So I think part of that relationship building was really important to me.
We're very happy to have you both. We're very excited for the case. Ravneet, if you're ready, I know you have an amazing case for us today. We can just start with the first aliquot and go through the case.
Yes, for sure. We're starting off in urgent care. We're seeing a woman for a chief concern of cough and difficulty breathing. She's a 73-year-old woman, and she's presenting to urgent care with a 2.5-month history of cough after she was diagnosed with a viral upper respiratory infection and bronchitis. She's here again for similar complaints because it's not getting better, and now she feels like she's getting short of breath, particularly with exertion. And the coughing attacks are impacting her during the day and even waking her up in the middle of the night. She tells you that she has a history of seasonal allergies, for which she was prescribed nasal spray and loratadine, which have led to some improvement, but the other two symptoms persist.
Thank you, Ravneet. Robin, I know it's still early with the information, but how do you usually categorize patients with cough when they're presenting with like 2.5 months of cough? How do you differentiate between the common causes, and is there any buckets that you can think of?
Yeah, such a good question. And of course, we see patients with cough in clinic all of the time. And so one thing that I definitely hone in on first is how long this has been going on. So I like to use my time frame to help me differentiate. Is this, you know, very recent, totally new? Has this been going on a while? Has this been lingering for a long while? And leading that to help me understand what specifically brought the patient in. So, is there a new symptom in addition to just the cough? Is it getting progressive? Is it getting more frequent? Is it really disrupting life? Which it sounds like it certainly is, both during the day and waking her up at night. So those are some things I ask about first. Of course, I have a whole host of questions that I'll want to dive into. But at least the kind of first thing that caught my attention is like, 2.5 months. That's been lingering for a little while. It At least what I heard was perhaps this was triggered by a viral infection first, or that was at least when she first noticed it. So that putting that away as well. And then a follow-up question I might have is when this respiratory illness came on, like tell me a little bit more about that. Did she get evaluated? Did she just stay at home? Did she get some treatment? Like what, are there other new factors that were introduced at the time of that viral infection that have occurred concurrently with this cough that's ongoing?
Yeah, thank you so much for the breakdown. Ravneet, back to you.
Yeah, so the additional information, this will answer some of your questions, is she's a new diagnosis of type 2 diabetes around 2 months ago. She also has a history of invasive ductal carcinoma of the left breast, for which she underwent chemo in 2014, and then the same year subsequently underwent a double mastectomy with reconstruction. She has a BRCA2 mutation. She has fibromyalgia, some anemia, and some chronic pain. And I can give you a couple more things. She has a long medication list. The two new ones are metformin and glimepiride. In addition to that, she's on atorvastatin, duloxetine for her pain, fexofenadine now for her allergies. She was started on a fluticasone inhaler when she had URI, in addition to the fluticasone nasal spray. And then she's on hydroxyzine and gabapentin. Some family history. No pulmonary history in her family. Some heart disease. She can't remember exactly who. And then she has a strong BRCA2 positive breast cancer history with her mother, maternal aunt, and sister.
Okay.
All right,
Thank
so
you so
I
much.
heard that the there are new diagnoses and some new medicines, both related and unrelated to this cough that you mentioned specifically. New diagnosis of diabetes with some new medicine started really around the same time frame, it sounds like, and then initiation of an inhaler and a nasal spray with maybe some improvement, but not complete resolution of her symptom profile. Yeah.
That's correct.
Okay.
Yeah, this is rich, adequate. Tameka, welcome to the virtual morning report. Sorry you're having connectivity issues.
No
You want to
worries.
just introduce yourself, and then I can recap the case.
Yeah, so I'm a second year pulmonary and critical care fellow at OHSU and excited to be here. Trained at Tulane for medicine and at OHSU for Pulm Crit.
Welcome. We look forward to learning from you. Ravneet is presenting an amazing case of a 73-year-old female with history of breast cancer. Sounds like presenting for 2.5 months of cough, which is like nocturnal and during the day. And now we get like some more information of about the history of diabetes as well, and a history of a chemotherapy as well, about 10 years prior. So just wondering, both of y'all's thoughts, do you factor in the history of malignancy and chemotherapy in terms of cough, and how does that factor into your thought process early in this case?
It definitely raises my concern for like possibly some sort of infiltrative disease, like an ILD. So I'm curious about like has anything made it better? Has it been like all the time? Has it progressively gotten worse?
And Tameka, I can add to that earlier. Her symptoms have been progressive. The new symptoms since being seen 2.5 months ago was the exertional dyspnea. And she has allergic rhinitis, for which she takes a fluticasone nasal spray, and that helped some with her allergy symptoms, but the cough and the dyspnea persist.
Any other thoughts that you all had before we can start with the next aliquot as well?
Yeah, why don't we go ahead and gather some more information, give Tameka a second to look at the board, catch up a little bit, and then we'll keep on moving along.
I can
Sounds
give
good.
you a little bit of social history as well. She's a never smoker. She's retired, identifies as a homemaker, identifies as biracial, Chinese and Hispanic. No known allergies. Okay, and then vitals at this visit, blood pressure, or excuse me, temperature. She's afebrile. Heart rate is 92. Blood pressure is 116/58. Respiratory rate 14. And then for her SpO2, we have a resting SpO2 of 95% on room air. And then with ambulation, she's about 92% on room air. Her exam is completely unremarkable, except for pulmonary exam with diffuse expiratory wheezing, normal effort.
And Ravneet, if we can also get the chest X-ray, I know that was the next piece of data before we can ask Robin and Tameka some questions.
Let's do it. Give me one moment to pull it up. This is a representative image that I found online. Can you see a chest X-ray?
Not yet. Now, yes.
I know some is given away at the top, but I think there's more to it than just that.
Okay, well, thank you for this, Alec.
Thank you.
Watts,
You wanna take
Robin,
a-
and yeah.
Oh, I was going to see
Robin
if
and
Tameka had any thoughts about the chest radiograph, or we could go back and then kind of discuss comprehensively, whatever sounds best to you.
Initial thoughts is it looks like it was pretty like equal bilaterally. That doesn't seem to be like a focal area of interest. And I could tell it was a upright and lateral, so AP film. The diaphragm, this may just be how she was positioned, but it seems like the hemidiaphragms are equal. So, sorry, my cat's crying in the background.
Yeah, I agree. I think, you honed in really nicely on looking at, is there something focal or is there something more diffuse going on bilateral? I think looking at, anytime you're looking at imaging, it's important to look at the distribution and the pattern of your findings. Because if we notice something, just a focal wheeze, that could, direct our eyes on imaging and make us think more critically about something that's going on just in one location. But diffusely in the lungs, this is impacting more than just one area. I see a brilliant comment in the chat about the differential diagnosis of wheezing. Lots of people think asthma right away, but actually there's a number of contributors to particularly, there's a number of contributors to wheezing, right? Wheezing is a sound that we hear when there's turbulent air moving through the airways. And so it isn't only asthma. Now, our patient here has asthma likely came to my mind and likely came to others' mind as well, as we're thinking about a patient who has seasonal allergies. Those two may go hand in hand, but not necessarily. We still have a lot to learn about our patient.
I'm also curious about her upper airway. Like, I feel like you can hear, like, some people characterize it as wheezing, but it may actually be stridor.
And we've learned the point that our patient is bothered by this symptom at nighttime. The cough is what she is reporting to us, but she's having some sort of symptomatology at nighttime. And so is that a positional factor? Is that symptoms are exacerbated at night by proximity to a trigger? Another thing to be thinking about.
And I don't know if we've already talked, sorry, go ahead. I don't know if we've talked about the common 3 etiologies of cough yet. Okay. I start thinking about, like, asthma. I think about postnasal drip, and I think of GERD as like the 3 most common. It definitely should not stop there, though. If there's other things that you're hearing on history or seeing on workup that may lead you into another direction, but those are some of the 3 that I think of.
Can I also ask, has she ever experienced a cough like this before that has lasted? You know, some folks, people certainly get post-viral coughs, and they can linger for a very frustrating amount of time. And so I would just be curious if our patient has experienced some sort of viral infection or a viral etiology and a lingering cough anytime in her past.
From her history, she did have COVID a couple years ago, and she did have a cough that lingered for a while, but it felt nothing like this. My follow-up question was going to be, in addition to additional history, if you have questions about that, is what workup would you be asking for? Because this patient is being seen in urgent care.
Take it away, Tameka.
Oh, I'm really glad that there was a chest X-ray. I'll just say that that is usually one thing I would like, and if they have access to like it's hard when a patient hasn't had experience with a peak flow meter. Like sometimes that can be helpful, but I would love a basic spirometry, but that's not really feasible at a lot of urgent care.
I'd also be curious about some blood work potentially, you know, wondering if she has an elevation of eosinophils in her blood. That is going to sort of categorize my mind as some, you know, lumping some diagnoses together as well. You know, I don't think we asked, I'm sorry if you mentioned this, does she produce any sputum?
It's a good question. It's dry.
Dry. Okay.
cough.
All right. All right. And has been dry all along. She's never produced sputum. She's never had any hemoptysis, anything like that.
That is correct. Dry cough only, never productive, and no hemoptysis.
And Robin, what were you thinking of when you're like thinking about the sputum? Are you thinking of like emphysema, like or bronchitis, like disorders, or are you thinking about infectious etiologies?
Yeah, potentially an infection. She had previously had a viral infection. You know, we haven't now gathered this history, but the virus could have sort of disrupted her lungs as a host environment, right? And that could predispose her to developing a bacterial infection thereafter. And so maybe that's part of why this could be going on and continuing to be bothersome. So just sort of wondering if she was producing anything, what that might have looked like, and if that could lead us down one path or another.
Yeah, thank you so much. Back to you, Ravneet. Oh, sorry, Tameka.
No worries. There's another thing that I was thinking about, especially with her cancer history and getting chemotherapy. If she had a different exam, and a different finding on chest X-ray, I would be thinking about, is there any concern for heart failure with a chronic cough positional? But it seems like she had like a normal heart size on her chest X-ray and doesn't have signs of edema on exam. So.
And one piece of history I didn't include, that she was asked about orthopnea and paroxysmal nocturnal dyspnea, both of which she said no.
What chemotherapeutic agents did she receive?
She, so 9 years prior to this presentation, she had received docetaxel and cyclophosphamide 4 cycles only.
And no radiation.
Correct.
Okay.
Are there agents you think of particularly when you're asking those questions that you're worried about?
I think about the oh gosh, I'm not the best with chemotherapy agent names, but I think of like the nibs and the mabs as causative for a ILD picture.
Yeah, we see immunotherapy associated pulmonary complications, certainly. I think you mentioned a taxane. Yeah, and taxanes can cause some pulmonary toxicity. I think 9 years feels like a long time to invoke that. But just as a teaching point, there can be some pulmonary involvement. And then radiation is an excellent question as well, because that too can cause some scarring in the lungs. Again, there's been quite a time has elapsed since her exposure. Patients can get radiation if they are then dosed with certain chemotherapeutics that can sort of reignite the pulmonary complication that the radiation may have caused. But at least so far, I'm feeling a little less suspicious about that given the time duration, but I look forward to learning more about the patient. And then while we are on the topic of medication, she did have metformin and glimepiride as new additions as well. I don't specifically associate those with her symptoms, but I would happily look up rare adverse effects from the medicines just to be sure. That's at least from a medication perspective, what I'm thinking so far.
That's perfect. Back to your needs for the further labs and workup.
So this patient was got the chest X-ray only in urgent care. Didn't get lab work at that time, but was sent home with a LABA ICS combination inhaler, and given she was told to schedule spirometry. So now you're actually meeting the patient while she's inpatient, and she has presented with hypoxemia. You are on pulmonary consult service and you have been consulted. CT chest is pending. They've ordered it in the ER. But you see she did get her PFTs done 3 days prior to presentation. So let me show you what her PFT, is that okay, Yusuf, if I show the PFTs? Great. And you just have spirometry.
Yeah, Tameka and Robin, I know this is what you wanted. If you could just simplify it for us, what are you looking at? What are you thinking of when you're looking at these numbers and the PFTs?
Sure. I'm happy to start. So I start by looking at the ratio of the FEV1 to FVC. I look at what her number is, and then I compare it to what you would expect based on somebody with her lung size and her lung age. So that's what our upper limit of normal and lower limit of normal will help us see, is she within what we would expect. So for her ratio is 88%. That's actually above the upper limit of normal, but I would consider that normal. Then I look at the FEV1 next, and I can see, again, I look at what she scored or what her values were, and then how she compares to someone of her lung age and size. And she's actually, her FEV1 is reduced. It's 55% of predicted. Then I see if there's a bronchodilator response, which she had a bronchodilator. We usually use albuterol in our PFT lab at OHSU. At our VA, we use Duoneb, so ipratropium albuterol. And then I look at the FVC, and that is also reduced. So when I see both a reduction in the FVC and FEV1, it makes me think about a restrictive process, and she has no bronchodilator response.
Yeah, that's great. I similarly course through my numbers that way. I think one other thing I'll just add is, of course, looking at the comments that the techs in our PFT lab have remarked upon, because sometimes we may see very deranged numbers and then reference a comment that says actually the patient struggled with some of the maneuvers, or there was some reason as to why we ought to interpret the numbers with caution. I just mentioned that, as you're reviewing PFTs that have been interpreted for your patients, that's something that we certainly rely on. Our very experienced respiratory therapists are excellent at coaching patients through their pulmonary function testing, but some of the maneuvers are very hard. And so it can be a challenge, and making sure that patients are certainly understanding the instructions and the best way to perform the maneuver, but then there are certainly reasons why they may have some difficulty. So I always want to make sure that I'm looking at not only the objective numbers, but also the subjective comments on how a patient performed.
And I don't know if everyone's familiar with Z-scores, but that is how we define mild, moderate, and severe. That's the new ATS guidelines that came out, I think, within the last 2 years. Maybe it's been about that time frame. So she, I think you would grade based on FEV1, but of course the spirometry alone is suggestive of restriction. You would need to have lung volumes to truly have that diagnosis, because it could also be obstruction with air trapping.
Perfect. And before I let you have you suggest any diagnoses, I know Ravneet has a little bit more workup that might be very significant towards your thought process. So Ravneet, if you want to give us a little bit more information, and then we can have them reflect on that.
Yes, of course. I'll give you some hard values, but also some trends. So she's in the ER. You see that her white blood cell count is 19, which is elevated. Her hemoglobin, hematocrit, and platelets are normal. And you do have a differential. And she has, you asked for an EOS count, an eosinophil absolute value of 2,740. And she also has an absolute neutrophil count of 12,630. These are her values today. Trend-wise, you look back because she had seen her primary care provider. She's just had some follow-up labs outside of that urgent care visit, and you notice that her white blood cell count had been slowly trending up, even though it was normal range. And 3 months prior to presentation, her absolute eosinophil count was elevated at 1,100.
And Robin, with this information, bringing in the PFTs, the eosinophil count, how do you approach like eosinophilia and lung disease, and how are you all thinking about this?
Tameka, you want to kick us off?
Sure. So generally, when I think of eosinophilic lung disease, I think of asthma like as one of my top thoughts. I would expect to see an obstructive process with possibly a bronchodilator response generally, but not always. It doesn't always fit perfectly as you want it to. I also start thinking about like chronic chronic eosinophilic pneumonia, and then I think about like drug exposures. There's probably others that I'm missing. I'll hand it to you, Dr. Stiller.
Yeah, there are some infections as well that can contribute to eosinophilia. But absolutely, you know, I think at least kind of broad strokes, in my mind, you know, I would so happily place together someone who has some allergies, has some wheezing, has elevated elevated peripheral eosinophils. I would have expected to see an obstructive pattern on her pulmonary function testing, but the objective numbers that we saw suggested restriction. And so there's a handful of things that, you know, we may want to think about moving forward. Tameka had mentioned lung volumes will be important. However, our patient is currently in a decompensated state, sick and admitted to the hospital. So now is not the best time to be able to obtain that data in particular. So we have to think kind of what else can we do to move us along right now. Has our patient traveled anywhere? Has she lived anywhere else in her lifetime? Sort of other life factors that may be important for us to know right now.
She identifies as a homebody. However, when she was really young, so maybe in her teens, she went to China to visit her family. And then a little bit later, she went somewhere in Southern America, but she hasn't traveled internationally since then. Otherwise, has been raised in the Pacific Northwest in the US the rest of her life and has lived here. And I apologize, Robin, you asked me another question aside from travel. Maybe I missed it.
I might have. That's great though. Okay, so it kind of a really remote travel history, but nothing. Okay.
But hasn't shared a household with anyone who's traveled, like
Um,
international.
She has a father who's elderly that she cares for, and she thinks he went back home to China like 5 years ago. That was it.
All right. I think as we were going through, we talked about primary eosinophilic lung processes. We talked about some infections, some other medication exposures. There are also some vasculitides. I think her age is, she's older than I might expect for a new diagnosis, but just again, sort of as a learning point, thinking about vasculitides that can contribute as well. And so I would be curious, all we've talked about so far is her blood counts, but I'd be curious if she has any suggestion of other organ involvement, and are we seeing, any compromise to any other organ system as well?
Like a UA by chance.
I love y'all's approach, including like the focus on the roommates who have traveled. I've never heard that question before. I think I can definitely put that in one of the questions of exposure to rare infections or organisms. And I like your approach of asking about other organs to think about, like vasculitis. It sounds like what you're alluding to. If you're thinking about like just asthma, is there like an eosinophil cutoff where you say, oh, this is definitely not asthma, or you can see very high E's with asthma as well? I was wondering.
I think you can see pretty high EOs with asthma if it's poorly managed.
Yeah, certainly. I think if someone has uncontrolled disease, then we can certainly expect their eosinophils to be pretty high in some patients.
Yeah, thank you both so much. But back to you, Ravneet.
Yes, so she's now hospitalized. She's on an inpatient service and her labs are coming in. They got her kidney function is a little bit worse. Her creatinine was 1.9. Her baseline is about 1. Her electrolytes were normal. Her liver function tests were also normal. She got a BNP or beta natriuretic peptide, which was normal. Thinking of the vasculitides and rheumatologic causes, all of that workup was normal. And so that included things like an ANCA, an ANA, and anti-CCP antibody, aldolase, which was all negative. She also got HIV and hepatitis labs, which were negative. Thinking of her traveling roommates, she did strongyloides testing, which was negative. Coccidioides is endemic to the Pacific Northwest in the US. So they tested her for that, which was negative. And given her eosinophilia, they got an IgE level, which was 2,500 elevated.
And at this point in the case, you mentioned hypoxemia. How much like oxygen was the patient requiring?
Yeah, so initially she was on 5 liters of nasal cannula to maintain saturations above 88%.
Thank you. Okay. Back to you, Tameka and Robin. Just thinking, like, what would you, if you're the consultant seeing this patient, would you recommend the team do next, or what would you want on your wish list as well of like things you would ask the team to get?
So at this point, I would love to see a CT chest, and part of the reason I would love to see that is because I really want to see where I should focus a BAL. I want to see what her eosinophils are with a bronch and BAL, because I think if they're high enough, then it may be diagnostic of an eosinophilic pneumonia. But I am worried with her oxygen sat, this may end up being an ICU bronch.
Does she have hobbies in particular that she likes to participate in?
Going along Tameka's train of thought, we wanted to ask those questions, but didn't get that far.
Are you thinking hypersensitivity pneumonitis, Robin?
I was thinking just in general, sort of kind of, does she like to be, you know, is she a gardener? Does she like to sort of be out in soil? That was one thing I was thinking about, exposure to some plants. That was kind of my thought process there. Ravneet, you had those questions and didn't quite get that far. Tell us more.
Yeah. Yusuf, do you want me? So I can tell you what happens to her and then we can look at the CT chest. So the team was thinking exactly the same. CT chest was done. They were planning to bronch. Her oxygen requirements continued to go up, so it was deemed unsafe. And unfortunately, she did end up intubated and sedated in the ICU, eventually getting a bronch, which I can reveal after the CT chest. So give me one moment. I have a video of this patient's CT chest with permission. They're axial images in lung windows. So just give me 1 second. Can you see the video? And then I will
Looks
start
great.
it. Right?
So it looks like there's patchy areas of there's some dense and some ground glass consolidation. It seems to be equally distributed. So any feel like any place of lavage would be fine, except for, so I'd probably target the ones that get the best yields, so right middle or lingula.
And I can give you a coronal too if you want. That's up to
Yeah,
you.
let's take a look.
If you can please just tell us like what you're seeing or what does
Yeah,
this
you
like
bet.
signify for you?
You bet. Yeah. The reason I think it's nice to look in different views because, again, as I had mentioned about the chest radiograph on a CT image series as well, looking at the pattern of distribution, and we can start to categorize, you know, do we see upper lobe predominant disease? Do we see diffuse disease? Do we see one lung more so than the other? Do we see sparing in the periphery and just centrally focused? So those are some things, you know, it's always hard on these because they kind of blow through on these videos, but to really look at everything. But we see, just as Tameka said, we see bilateral findings, we see diffuse findings. There is not, I don't appreciate sparing of the periphery. It looks like some of the findings do go all the way out to the periphery, and some variations on the density of those opacities, ground glass, but there are some areas that do look a little denser to me. So that is at least kind of a first glance, a first thought. But again, when you're going through these imagings, really thinking about the pattern of distribution, and that's why multiple views can be helpful, because that can help us narrow our focus a little bit. I was looking mostly at the parenchyma, but also you want to look at your airways too to see if there's something specific in one of the airways that catches your attention. If there is you know, a narrowing, if there's debris in any of the airways, if you're seeing bronchiectasis, you know, some dilation of the airways, those are some other things that can be helpful to at least make note of as we're moving forward here. And then also to Tameka's point, you know, if we see a specific area, we will target that for our bronchoscopy with lavage. We want to collect a sample from a specific area. Here, she has diffuse findings. And so moving toward collecting a lavage sample from the right middle lobe or the lingula. Those are nice options because they really increase our yield. What happens in a bronchoscopy is we deliver some aliquots of saline and then suction those cells back. And with that comes the cells that are comprising these opacities, right? That's our goal, to try to collect some of those cells and then send them down to the lab for evaluation to learn what is making up those findings. And it can be hard to get a good, just because of gravity, it can be hard to get a really good return from the lower lobes. And again, sometimes it can be hard to get exactly where you want to, but the middle lobe and the lingula really nicely allow for us to access those airways, and then we get pretty good return just based on patient positioning.
Perfect. And Raveen, what was the official read for the CT scan? Did they give anything else from the official read, since they had it more time to look at the details?
Yeah, so they said similarly, diffuse ground glass opacities with areas of consolidation. They called interlobular septal thickening, but then they said a particular term called crazy paving.
And Ravneet, will the next aliquot reveal the diagnosis, or do we have one more aliquot?
I have some BAL studies because now the patient is intubated in the ICU.
Yeah,
And
I think.
I have a cell count for you for bronchoscopy. It is 37% eosinophils, 50% neutrophils, 7% monocytes, and 2% basophils.
That's a lot of EOs.
What are we normally looking for?
Sometimes 0. 0 can be normal. Definitely less than, even 5 would be pushing, you wouldn't see that commonly. So this percent is a hyper-eosinophilic process.
You had mentioned that she had a trend in her peripheral EOs 3 months prior. Do we have anything farther back than that?
Unfortunately, we only have one CBC with differential from when she was getting chemo 9 years prior.
Years ago, yeah.
Normal. The rest are CBCs only.
Got it. Okay.
Yeah,
And
it sounds like, sorry.
The one other question, I understand her respiratory failure is progressing. It seems like pretty in stages, right? So this has been going on for an subacute, maybe even pushing acute time, chronic time frame, right? Because another thing to think about is she noticed this 2.5 months ago and noticed some worsening dyspnea. Sometimes patients have symptoms that precede something that is so bothersome to them that then they report it, right? Like people find ways to, they may find ways to accommodate, or perhaps she is not terribly physically active at baseline. And so she didn't quite notice that she was having these symptoms. So I think the time course there may not be completely clear. So something's sort of been trucking along, but it seems like in a rather acute time, she is getting precipitously worse, is at least what I'm gathering here. She had to come into the hospital. Her respiratory failure is progressing such that she required intubation and admission to the ICU. I'm curious if she is having other manifestations of hemodynamic instability. Is she developing shock? Is there, other things going on too, as far as her overall clinical picture?
I can answer some of those. And Yusuf, this might lead me to my last aliquot. Is that okay with you? Okay. So her course, she develops a distributive shock. Without a clear etiology, the rest of her infectious workup is negative. And then she just has an AKI through this course. She's on and off pressors. And as a result of the findings on her bronchoscopy and her chest imaging, she was started on high-dose IV steroids in addition to broad coverage with antibiotics. She improved briefly and was extubated for under 48 hours and then reintubated. Over that time period, her peripheral eosinophilia completely resolved. And then she did end up getting a repeat bronchoscopy when she was reintubated, which showed an eosinophil percentage of 5% and 85% neutrophils. Unfortunately, the patient had really high ventilator requirements. So the suspicion was now she was developing an irreversible lung injury that wouldn't be surmountable. And so the patient decided, and her family, excuse me, her patient's family said she would likely desire comfort-directed care. Went on comfort care and passed within a day. And the family did give permission for an autopsy. And the autopsy ended up showing a microscopic evaluation of lung tissue with eosinophil-rich inflammation and alveolar damage in stages of organization. And so the final diagnosis was chronic eosinophilic pneumonia with a background of organizing pneumonia.
Yeah, I think seeing the trend over time, a chronic process makes sense. I will highlight that folks who have, we're talking about chronic eosinophilic pneumonia. There is a acute eosinophilic pneumonia diagnosis, and those patients are very, very sick. Not to undermine how sick our patient got, but when you first meet a patient, that is a differentiation point, because folks with acute eosinophilic pneumonia are, pardon me, very critically ill typically.
And that diagnosis is associated with a really high mortality as well. And they can come in like completely, like have a normal history, living their normal lives, and then suddenly like progress to needing intubation, and it's a very quick time frame.
And classic of these eosinophilic processes, we see eosinophils really melt away when steroids are initiated. So I'm not at all surprised to hear that on a follow-up evaluation, the numbers were markedly lower. There's a question in the chat about the cause, and it can just happen. It can be an idiopathic process.
I think that's one of the frustrating parts about these like acute and chronic eosinophilic pneumonia is that we don't often have an etiology to tie it to.
Wow, thank you both for your reflections. Ravneet, thank you for the amazing case. How was it caring for this patient, and how was your experience? Were you on the consulting team or the primary team?
I joined her care actually right when she transitioned to comfort care. So I got to learn about her after she passed, and spent some time learning about her from her family, and when we got permission to do the case. I think I've seen a couple cases like this where we don't know what caused the initial insult or injury, and then patients just end up on a ventilator with irreversible lung injury. And so I mean, it brings me back to why I want to do pulmonary critical care, which was being engaged in those really meaningful conversations and helping people get the death that they want and deserve once they reach that stage. And that's a privilege and an honor that a lot of people don't have. So I think from a humanistic perspective, that was very valuable. I think with just looking from a medical perspective, if we look at the differential for acute eosinophilic pneumonia, we spent some time trying to figure out if any of her medications, including the glimepiride and metformin that she was started on newly around the time of her symptoms, could cause it. And those aren't the typical agents we think of, and there were no case reports either. There is a laundry list of medications from something as simple as Tylenol to being on venlafaxine, to being on phenytoin for their seizures. Those things we typically think of, and she had never been exposed to any of those. They ruled out most of the infectious causes that I didn't present here. Of course, no HIV, no fungal infection or parasitic infections with the strongyloides workup. And then she didn't have a leukemia history either.
Coming back to your point about the medications, I take every opportunity I am given to run my medication list with our colleagues in pharmacy. We are lucky in our ICU to have a dedicated clinical pharmacist who rounds with us, and they are just an absolute wealth of knowledge. So would highly recommend at any opportunity to just sop up some knowledge from your colleagues in pharmacy.
And one thought is if we would have identified her peripheral EOs sooner, I wonder if we would have thought about an eosinophilic targeted agent, like mepolizumab, omalizumab is really IgE focused, but I'm just Benra. There's a whole list.
Yeah, and folks who have asthma with eosinophilic predominance, we have our kind of standards of care for up-titrating our asthma treatment, but then there are these amazing new agents as well that are targeted and can really change people's lives and actually reduce their, they receive these medications and it can, pardon me, reduce the frequency that they have to rely on their inhaled therapies.
Yeah, I remember those being they're on the medicine boards now as well, the new therapy, asthma plus eosinophilia therapies. Robin and
And
Tameka,
you're absolutely right. Steroids is where we start when we're
Yeah.
treating these eosinophilic processes, as you mentioned in the chat.
Perfect. And is there anything you want like trainees to take away from this session, or any reflection or two you wanted to share?
To Ravneet's point, I completely agree with you. Like, one of the most powerful things that we can do for our patients is provide them a good death. And that's I'm really glad that you took that away from this case, because it can be really hard working in the ICU at times when you're constantly surrounded by hard cases and don't always get the outcomes that you're hoping for. But just remembering, like, we're all like, it's all a trajectory, like it's all like a spectrum, and meeting people where they are and listening to what they want and how they would want to live their life and what is a good death. And I think that's a really wonderful thing that you took away. So I just like to try to remember, like, we're trying to be good people as well as good doctors.
Yeah, absolutely. We are privileged with being welcomed into these families, right? We get to partner with them as we are honoring their loved ones' wishes. And so I couldn't agree more. It's a really special aspect of ICU care. And then, also taking a step back and thinking of some of the other clinical takeaways here. I think, Yusuf, you had mentioned a question that wasn't previously in your question bank, right? And just, thinking creatively, if you're not quite able to piece the case together, kind of reword your question for yourself. And that might make you think of, another exposure, another hobby, just some other aspect of this patient's life that we haven't yet explored to help us maybe open a new door and figure out what may be going on.
Yeah, thank you both. It's a really humbling case, but we appreciate that we were able to learn from it. Thank you, Ravneet, for bringing it. Thank you, Robin. Thank you, Tameka. Thank you, everyone, for joining. We appreciate you. Hope you have a wonderful day/evening, depending on where you are. And take care.
Thank you so much.
Thank you all.